I am pleased to present what we've been working on for the last 4 or 5 years on the unexpected newborn complications measure. This is work that I've done with Dr. Jeff Gould and with Anisha Brero, our senior analyst, and it really is kind of a fun journey. We're going to talk about the importance of measuring term baby outcomes and trying to get an appreciation for all the balancing that we had to do to reach that. It is about getting the right balance. We have interests to balance between the mother and the baby. We have to decide whether we're going to focus on all babies or a specific subgroup. And is the definition for a term baby outcome going to be very narrow, or is it going to try and be comprehensive? There are lots of pluses and minuses here, and we're trying to strike the right balance. In addition, with any measure that's going to be used widely among hospitals, we have to balance efforts to get the most accurate measure versus the data burden to collect it. And there is middle ground in all of these. And then we're going to spend a fair amount of time talking about coding issues, since when you're talking about measures that you're going to try and collect for every single term baby, that's hundreds of thousands in California, we have to use administrative data. And as everyone on the call knows, administrative data has pluses and minuses with how the coding is done. There is issues both with overcoding and undercoding. And we'll try to give an appreciation for how we handled those issues with our measure unexpected newborn complication. So let's start off with asking the basic question: what is the most important pregnancy outcome for mothers and their families? You know, as an obstetrician, I often talk to mothers, and the answer was always, we want a good take-home baby. That's partially my language, not necessarily theirs, but that was the clear intent for all the mothers and families that I've worked with. It is not necessarily avoiding a cesarean or episiotomy or other maternal morbidities. They don't really come close to having a good take-home baby. Those are important, but in a secondary way. Though classically, these are the measures that we have used for measuring our estimate of quality of maternity care. So this effort over the last couple of years was to try to bring back that balance between mother and baby for term babies, which is, of course, the bread and butter of obstetrics and the vast majority of babies that will be born in the United States. So if this is so important, why aren't we measuring them? What are some of the barriers and issues that have been in the way of having good outcome measures for term babies? We have to decide which babies qualify for the measure, what outcomes we're going to look at. There is a pretty low rate of poor outcomes among term babies. That makes measurement a little trickier if you're trying to discriminate between among hospitals or other settings. And then the last question is one we'll talk about some toward the end, which is, are poor outcomes in term babies related to the care, or was it out of folks' control? This has been contentious as we've started implementing this measure, and I think the answer is that a fair amount of it is under the control of obstetricians and pediatricians. And that's something that we can work toward and talk about. So let's start. Which babies? All babies versus term babies. Preemies have a wide range of outcomes that are related pretty directly to their gestational age and birth weight and their intrauterine environment, i.e. Whether they have a good blood supply through the placenta, and a whole variety of other factors. So they're a tricky lot. We can't really consider them to be a homogeneous group. So in this measure, and most people's looking at it, we're looking at term babies over 37 weeks of gestation. Now that's still a range, and we'll show some slides showing the difference between 37, 38, 39, 40, 41 weeks. but nonetheless, that's much more homogeneous than trying to mix them in with preemies. And this is an important principle here. It's about expectations. I want to structure this measure as really a discussion of what parents expect. And they clearly don't expect preemies to have the same outcomes as term babies. Preemies aren't expected to go home or have perfect outcomes, whereas that's where we are with America right now, is that term babies are expected to go home and to have perfect outcomes. So let's start with some of the earlier attempts to measure term baby outcomes. And there are strengths and weaknesses to all of these, and we'll try and get a sense of what has been our predecessors here and how these have informed us as we've developed the unexpected newborn complication measure. Now, one of the ones that I actually have liked in the past is the rate of term baby NICU admissions or term baby NICU length of stay. How many days did you spend in the nursery? How many days of term baby NICU stays did you have? This is actually trickier than it seems because NICU admissions is not coded in most states as a part of the discharge diagnosis file. And so it's not actually directly capturable. In addition, hospitals vary on who gets sent to the NICU, and it can vary by time of day, it can vary on staffing, it can vary on hospital policies and protocols rather than something intrinsic to the baby. So that makes it problematic. So the one that has the widest play is the ARC measure, Patient Safety Indicator 17, birth trauma rate. We're going to go through this in the next slide in a moment. And we're also going to discuss a one that from Kim Gregory's group at UCLA called the Ideal Delivery Rate, which is births without major complications, somewhat similar, and we have worked together on some of these in the past. And then a typical research approach is illustrated by the Maternal Fetal Medicine Units Network, funded by NICHD, looking at composite neonatal outcomes. Let's look at the ARC measure. The ARC measure is a very simple measure. It is some 7 or 8 ICD-9 codes. But interestingly, it's taken out of the, quote, universe or the bigger piece of overall birth trauma. So we have two circles here in this nice pie diagram. And this is an analysis of PS17 birth trauma. And it was really the first one to be done, even though this measure has been around for 10 or 15 years. Is the first one that really analyzes it by code. This is actually an important thing to do when you're developing a measure, is to look at what codes are driving it. Is there a code that is a dominant code? Is there codes that are sort of more marginal quality that you have to worry about? These are all key things to do when you're starting evaluating a measure. So let's look at the left large circle, and this is all the birth trauma codes in the ICD-9. This is how it was defined initially. The big one, that's 3/4 of it, 78.24, is the measure for cephalohematoma. And the other measures that don't fall out, the PS17 is the small circle to the right. So it's only that piece of, 78% was the cephalohematoma, which the code is 767.19 in the legend in the bottom. So of all the birth trauma codes, 9% fall into the PS17. Excluded in the other 90% of birth trauma codes include fractured clavicle, brachial plexus injuries, or facial nerve injuries are not included. As is typical for composite codes, PS17 was created by an expert panel who said, well, we like this code, we don't like that code. They didn't like clavicle fracture, brachial plexus injury, or facial nerve injuries because they said, well, these may not really be the result of the obstetrician's care. It was a shoulder dystocia, et cetera. So they didn't want that into the birth trauma code. So those were excluded. And then we have this 9% that create the birth trauma code. And you look at the codes that make it up, and some make a lot of sense, like epicranial subaponeurotic hemorrhage, which is otherwise known as a subgaleal hemorrhage, which can occur after a vacuum extraction. Very important birth injury. That's the one that is the straight crosshatch. Others include injuries to skeleton, other peripheral nerve injuries, and subdural and cerebral hemorrhage. What drives this measure, though, is the big white section that's over 50% that is other, specified birth trauma. And there's another code in here that's, that's just other injuries here, other injuries there. You really have to be careful about when a measure is over 50% of unspecified codes or unspecified conditions that fall into an other category. That's a major concern because, first of all, the rate is low. We're talking about overall on the far right, you see the PSI rate at PSI 17 is 2.45 per thousand. So it's only 2 per 1,000, and half of it is other codes. So it's actually pretty easy to improve this measure by cleaning up your coding. All trauma is with the big circle on the left is 25 per 1,000 or 2.5%, but only less than a tenth of that falls into this. Interesting, the point of this article was to look at the PS17 code between C-sections and vaginal deliveries, and interestingly, in the all trauma code, there is a significant difference between C-sections and vaginal delivery. C-sections has many fewer, half as many, 0.05 is the odds ratio, for the codes represented overall for birth trauma, largely because cephalehematomas are more often with the vaginal delivery. They are not particularly a serious birth trauma, as they do remodel and go away in a few days. But if you look at the birth trauma within PS17, it's actually more frequent with C-sections than with vaginal deliveries, which is a little disconcerting. So the critique is that PS17 only represents a small set of birth traumas, a very low rate, dominated by nonspecific codes, and it's so easy to show improvement. This has happened in a number of QI projects around the country by reducing the number of quote, other birth injury cases that get coded. And it's a pretty narrow view of birth outcomes, just looking at these kinds of birth injuries. So it's not in balance. But it is easy to calculate. And I don't want to diminish this fact, and that's why it has survived for more than a decade. This is not NQF endorsed for these reasons that we've gone through, but it has been used by a lot of projects around the country because of the hunger for a measure of this type, and it is easy to calculate. You just run your ICD-9 codes through a protocol and you get it. So let's turn to another approach to measures, which is very similar to ours. Gregory's group was looking at whether you measure adverse outcomes or ideal rates and trying to get rates of, quote, the ideal delivery, which is how we started off with calling this measure healthy term newborn. So what is the rate of healthy babies do you get out at term? But the approach is the same. You first look for bad outcomes and exclude those. They define it as death or transfer, all codes for birth trauma, RDS, other respiratory problems, infections, and so forth. And they got a rate of about 10%. Many of the complications, though, had very short lengths of stay. When you get a whole lot of IC9 codes, you have to be careful about whether you're picking up codes that aren't really that sick. This is clearly a better measure than the ARC one. It's a little bit of a high rate, though. 10% of term babies that still have major complications, and particularly since they had short lengths of stay, suggesting they were minor issues. It has not undergone vigorous field testing to test the different codes. So the last one I want to use as a foundation for where we're going is the MFM network, example of a neonatal composite typically used in research. And again, it's death, RDS, TTN, so some specific codes. They don't really specify in their journals, in the publications, exactly which codes were used, but you can make a guess. But we're going to show in a moment that the actual codes make a big difference. So what you see here, and this is typical of most neonatal composites for neonatal outcomes at term, is that they're dominated by respiratory and sepsis diagnoses. Those are the major issues for term babies. This is was used in this particular study for repeat C-sections, and there were a lot of those at 37, 38 weeks, so it's not surprising that there are a lot of respiratory complications. And half of it is RDS and TTN. Interesting, when you look at this, you also see that the NICU admission was 16.4, third line from the bottom, and the overall combination of the respiratory and the sepsis was essentially 16. So the composite outcomes altogether was 16.7. NICU admission, if you looked at it alone, was 16.4. So it's pretty much the same. So how did we approach this? We started with a concept initially of healthy term newborn, and that ended up with rates somewhere around 96%, with rates between 94 and 98. And pretty soon, after response to users and to field testing, became clear that people had a hard time telling the difference between 94 and 98. They both sound like good grades. They're both A's. And we turned it to the inverse. So instead of measuring healthy babies, we measured unexpected newborn complications, which, as you'll see, range around 4%, 2 to 6%, and people can tell the difference between 2 and 6% easier than they can between 94 and 98%. Importantly, our approach was to set aside all babies with pre-existing conditions. This was important to identify where families' expectations are lowered, because again, this is working with families and identifying what they would perceive as illness in their babies. So we excluded off the top all preterm infants, all small for dates babies, and all twins or multiple gestations. Those families recognized are a more complicated game. Also, all congenital anomalies or malformations and conditions, big or small. It was hard to draw the line, so we excluded them all. what's small or medium or large in terms of the congenital malformation varies in the eye of the beholder, so we decided to exclude them all. And we also excluded fetal diagnoses, eye drops, for example, intrauterine acquired infections, and drug withdrawal. And really focused in on that #1 goal for the family, which is a healthy baby, like this one that I delivered. So the devil's always in the details here. We needed to use administrative data to minimize the data collection burden, and we knew NICU admission was not a code that we could use, and the reasons I spoke earlier, it was not an appropriate thing to do either in terms of grounds for admission vary quite a bit. We also wanted to separate out severe from moderate complications, and we're going to show you how we did that. Because both are important, and you want to gestalt, but you also want to be able to drill down into what's severe. And also to make this operational, because at the end of the day, this is about quality improvement as well as measurement. And you really want to be able to help folks figure out where to go to improve their unexpected newborn complication rate. So we have buckets, if you would, or groupings of code into distinct diagnosis categories to facilitate QI projects. And we spent a lot of time providing safeguards for overcoding and undercoding because we are essentially fully dependent on ICD-9 codes. We wanted to extract everything we could from them. So for the unexpected newborn complication denominator, we started off with singleton lipers with the ICD-10 codes for those. We did confirm with birth certificate data that all these births were over 2.5 kilos, which is the definition of small for dates, under 2.5 kilos at term, and that they had a gestational age over 37 weeks. The ICD-10 codes for gestational age are not the best, particularly when you're looking at term. They're a little bit better at picking up preterms, but the 35 to 36 weeks is pretty vague and often not coded one way or the other, using an ICD code. Obviously, it is in the birth certificate, and we are using, as now recommended, the obstetric estimate of gestational age, not the last menstrual period gestational age. So that's the inclusions. The exclusions are all congenital malformations, which are grouped together in ICD-10 under the Q code section. We excluded all the congenital anomalies that we could, congenital disorders that we could find, and these are selected from the E and G code set. And then other placental conditions, infections, high drops, RH sensitization, those are in the A and P code sets. As anybody who has worked with ICD-10 knows, this ends up being a couple thousand codes. So they're available all in an Excel spreadsheet to use, but ICD-10 is not parsimonious when it comes to coding. So you have every part and parcel, or every option, or every possibility is codable. Put it that way. So then we wanted to categorize the complications from the viewpoint of the family. And so we divided them into severe and moderate. Would I be fearful of my baby's survival or long-term outcome if my baby had X or Y? The second frame we use is, would I be upset or concerned, maybe not fearful of the long-term survival or outcome, but would I be upset if my baby had X or Z outcomes? And we did not include the concept of whether this was a totally not preventable condition at birth. This is, again, these are pregnancies that the mother comes in expecting everything to be right and to have a healthy baby at the end. And so these would be unexpected then term newborn complications. So we put these into buckets. of different types of complications. And an example of severe birth trauma / neurological, and we did combine these, would be intracranial hemorrhages, nerve injuries, APGARs at 5 minutes or 10 minutes of 3 or less, so pretty strict APGARs. We found very quickly that APGARs 5 and 6 actually did well and didn't really have much neonatal morbidity. So this is really low APGARs at 5 or 10 minutes. We included here organ injuries, major fractures, HIE, leukomalacia, and we included not only diagnosis codes, but procedure codes, and we're going to get into that in a moment. Severe infection is the second bucket, was severe sepsis, and sepsis with a longer length of stay, and we're going to come back to these red elements. Severe respiratory complications are pulmonary hemorrhage, meconium aspiration, ventilator, chest tubes, nitric oxide, ECMO. Notice we don't have RDS in here, and we're going to discuss that in a moment as well. Severe shock and resuscitation is ATN, cardiogenic shock, a lot of monitoring devices. If you hadn't been picked up above, we'd pick you up here. And lastly, in the severe, is the disruption entailed by moving a baby from the hospital delivery to a higher level of care. That's a major event in a family's life, to have to transfer a baby out, maybe take the mother, maybe not take the mother to go with her, and it's a big deal. So when we started getting the feedback from our first pass and started seeing how people actually coded as opposed to how we thought they would code as an expert panel, we learned some interesting lessons. And so we had some needs that appeared, and we needed to protect against overcoding. One of the very first ones was sepsis. Sepsis seems pretty straightforward, but there were hospitals that seemed to have very high rates of sepsis. When we inquired, they went back and looked at their records, and the coders were coding rule out sepsis as sepsis. And so for sepsis, as opposed to septic shock, but for sepsis, we added a length of stay requirement. If you truly had sepsis, you're not going to get out of the hospital under 4 days. Rule out sepsis, on the other hand, often has a day or 2 or 3 of antibiotics, and then they're stopped and you go home. And so the length of stay modifier here actually works as a pretty good screen. So sepsis required a length of stay of over 4 days, and that was an overcoding protection. Undercoding was another issue that came. We know physicians aren't always the best at documentation, and coders are limited to what the doctors write in their notes for coding. And so there can be diagnoses that are missed, that aren't coded. And then there are also situations in which hospitals decide they're not going to use certain codes. And this is something that we do run into with the perinatal asphyxia type of codes. Some hospitals just don't use hypoxia codes. However, they use procedure codes because those are tied to billing. And so we really wanted to have a combination of diagnosis and procedure codes whenever we could. So we have, for example, if you have significant RDS and you're on a ventilator, the ventilator captures you, even though the RDS may not be something that would put you in a severe category. So we use both the codes, diagnosis procedures, whenever possible, to put someone in the bucket. And that's the purpose of nitric oxide, EEG ventilator, ECMO, are all severe respiratory complications, represent respiratory complications. So that was severe in examples of those. So now in the moderate bucket, and these are again conditions that would worry a family, but they wouldn't necessarily fear for the kid's life or long-term outcome. And these would be facial nerve injuries, clavicle fracture. Clavicle fracture can happen even in the best of deliveries, but it does worry families quite a bit. And so we did include this in, again, from a family-centric viewpoint. We did add a variety of things to this that had a length of stay requirement. We started off with CT or MRI as procedures that would be a marker of neurological injury, but then it became clear that these could be done for follow-up of ultrasound findings prenatally and may not truly represent anything at all. And so, as an example, this is part of a group of codes that need a length of stay requirement in addition to the code being present. Likewise, for moderate respiratory, such as RDS or TTN, TTN or atelectasis requires a length of stay, and RDS or emphysema pneumothorax would be in the moderate respiratory. Those are short-term problems, generally resolved pretty quickly. CPAP falls into this as well. So let's talk about coding strategies again. So over-coding protection really requires us, there's lots of codes that could indicate a significant illness, but they also can be easily over-coded and the baby actually goes home in 2 days. That's probably not even a moderate morbidity. And so we wanted these codes to have a length of stay that meant that they stayed longer than expected at a minimum. So that's over 4 days for a C-section, over 2 days for a vaginal delivery. Postpartum length, or this would be the newborn's length of stay, obviously post-delivery. Undercoding protection, we had some cases that had very few codes, but a very long length of stay, 6, 7, 8 days, which is pretty long for a term baby. And this is suspicious that it had a morbidity, but weren't necessarily being coded. So we thought about what else keeps a baby in the nursery for a long time. And neonatal jaundice was one of the leading indicators. We didn't want to actually have this as a morbidity because we thought this was part and parcel of the newborn development issues. And so we screen these cases to see first if they have jaundice or phototherapy, or it's a part of the social reason why they're staying there, such as homelessness or child welfare custody, or the mother's in a residential institution. There are codes for those, and we exclude those. So if there's none of those excluding codes available, these were considered moderate morbidity if they had a long length of stay, much longer than the mother. So this is at least 5 days in a term baby. So what do we get?
Elliott?
Yep.
There are a couple questions.
Sure.
Question 1, where do you get the ICD-10 code list for the different conditions? Okay.
So we have that as part of, and maybe Ann can answer this.
Yeah, I'm happy to.
With all the codes, every single code. Go ahead, Ann.
Yeah, so for maternal data center participants, whether you're in California, Oregon, Washington, then you can go to the maternal data center. The top black bar has a support link. It's usually the last link in that top black bar. If you click on support, then you have a whole host of user guides and measure definitions. So you go to the section labeled measure definitions. You will be able to download the all of the different UNC codes as well as summaries and algorithms for that.
So this is probably the most complicated measure we have in the data center because of all the potential codes. It's a mega composite. And so normally it's on the side of any display for that measure. We give the measure definition. This is in a different spot. And it's because it's a big, long Excel spreadsheet. But all the codes are there, both ICD-9, ICD-10, with the code and the code's name, the formal name for it, and they're divided into the buckets. So we tried to make it as easy as possible, and then the algorithms actually show how they're put together to assemble the buckets, and what's severe and what's moderate.
Okay, so next question. With level 1 hospitals, CCS requires transfer if more than 6 hours of care is required. Will this be taken into account with your severe complication rate calculations?
No, it is. If it's a newborn transport, it's a newborn transport, and it is a significant disruption to the family to have to do that. So that is one of the drivers for severe maternal morbidity, for UNC in smaller hospitals. As you'll see, though, their rates aren't, if anything, are a little lower than the big hospitals, even with that in mind. Part of the reason for that is that we do want people to screen their term babies as much as they can. And if you have to transfer a baby, there's generally something wrong with that kid, obviously. And so that would fall into a morbidity for sure.
Okay, and one more question. This person says, our coders are coding CPAP for delivery room resuscitation when they've had a minute of CPAP in transition than normal newborn care. Is this indicated or something to work with coding on as overcoding?
It's an overcoding. This has actually been an issue that some centers do that. We're going to talk about that in a moment in a little bit more detail. But it is something that we have seen that's a coding practice. Perhaps to justify some types of billing, but it's not the intent of the code to do a minute or two of bag and mask. So that's we may revisit that, but that's a somewhat isolated coding practice. So this is what we see in this slide about the distribution of a histogram of the distribution of UNC rates among California hospitals. So this is representing 240 hospitals, and here it's rate per thousand, not percents. So 40 is 4%. The California mean is 3.9%. And you can see it goes from basically 1% to a few that are 8 or 9%, with big peak between 2 and 5%. Is what you're really going to be seeing. It gets interesting when you look at the sub-measure calculation. These are the buckets. And as was seen earlier, the two biggest buckets are respiratory and infection, and they're about half. They're not, everything, but they're about half. Now, transfer to higher level of care, and this is level 1 to level 2 to level 3, et cetera, is about 15%. Now, this could obviously include other diagnosis categories besides, it involves obviously respiratory infection or birth injury, but they're often in these transferred babies, not a robust set of codes that would make us able to really sort it out necessarily. So we kept this as a separate bucket. Neurologic and birth injury is about 12% of all the uncodes, and shock resuscitation, another 12%. And then there's this 8% who had a really long length of stay without any clear diagnoses after excluding for jaundice or phototherapy. So this is the proportion in a pie way. If you look at the right column, this is the actual rate. And again, if you wanted to look at percent, you multiply by 10. So respiratory complications is 1.3% or 13 per thousand. And likewise, infection is about 0.5% or 6 per thousand, et cetera. So this gives you a sense of the overall type of rates. So we did this has been to the National Quality Forum, and it actually was approved some 4 years ago and then reapproved just a few months ago. Anisha in CMQCC did a lot of very detailed work to get the measures through the NQF process. We did some face validity that I'm going to show in the next slide when we get to it, comparing it to neonatal morbidities tracked by NPIC. We did formal reliability testing. This is a very detailed statistical testing that involves variation among hospitals and incidence or frequencies. And the take-home message here is a good measure is 0.8 on this score, and an excellent measure is 0.9. and the UNC measure came in as 0.92. So this made everybody very happy that this was a reliable test to use. And we looked to see whether there's a lot of up and down variation. Now, obviously, within month to month, there could be, because this has a relatively low rate of 3 to 4%. But looking at 6-month intervals over sequentially, we didn't see much variation, so it was a stable rate. So this is an interesting little mini study that we did looking at UNC and at the bottom in the blue, and some of our big submeasures compared to weeks of gestation at term. And this is the y-axis is odds ratio comparing to 39 weeks. And so 37 weeks was twice as high, or 1.5 as high for a number of the measures, and it also went up to that same level at 42 weeks. So 42 weeks was as bad as 37 for morbidities. The top one is from NPIC, which is a big quality improvement organization, perinatal data on the East Coast, sort of analogous to CMQCC. And they've used this measure extensively as well, and they got the exact same type of curve with the same odds ratios when they looked at NICU admissions at each of those. So this really tracks very, very well with NICU admissions. So that's a face validity test. Now, when you look at NICU levels, and we've done this a couple different years, and we get similar, slightly different results, but they all trend the same, is that regional NICUs tend to be a little higher. Intermediate NICUs also a little higher, and community basic hospitals are a little lower, suggesting that there's maybe some case mix differences, maybe some choice of where certain mothers deliver, or maybe there is more intensity at bigger hospitals. But this is an important find. But look at the variation among each of these levels of care. This is the CCS California levels of care, which is sort of like a 1, 2, 3, 4, pretty close to that. But there is big variation among each of these levels of care, so there's overlap. NPIC saw pretty much the same, what they show here. This is regional academic centers with moderate and severe added up together at 3.5%, and they see a similar type of variation around that. Academic level 2, 3 on the far left is also elevated, whereas their small hospitals tend to be a little bit lower, but still within the range of each other. This is a scatter plot of normal term births, or UNC, on the y-axis, and the total number of births per hospital on the x. So this addresses the question, does UNC vary based on hospital size, which is different than hospital level, and it's pretty scattered. So there is not a clear association between size and UNC rate. It comes out a little bit when you look at level, but this was of interest as well. So this has raised the question as whether we need to do risk adjustment for this. Obviously, the differences among NICU levels could indicate a need. Again, case mix, are there more maternal disorders? We did not exclude moms with hypertension or diabetes from this. There aren't that many moms with type 1 diabetes in any of these data sets. If you were to exclude all hypertension, all diabetes, that's 20–25% of patients nowadays, given our obesity, and that diminishes the value of the measure in terms of its applicability. And we already have excluded babies that are IUGR or premature, so those are the ones that are going to be most affected by hypertension in any case. And then there's an open question about whether there's a lot more billing for CPAP, for example, at level 3 centers, level 4 centers. or more aggressive treatments, and so that's the one that's a little tricky to answer. So this is a point that we're actively pursuing. This is why it's not out there as a clear performance measure, one hospital to one hospital. We're recommending that it be compared against other hospitals at the same level or at the same hospital over time. And that's a very valuable thing to look at, is to have a measure that you can follow newborn activities over time, and this is where we see a great value of using this as a balancing measure in our C-section projects. Now, the next two slides are an interesting thing that I just recently put together, which is what is the effects of race and ethnicity on UNC? We know that there is big racial disparity in a lot of neonatal outcomes, a lot of pregnancy outcomes for that matter. Maternal mortality is 3 to 4 times higher. Infant mortality is 2 times higher. Prematurity rates are higher, et cetera, et cetera. But this is a little different. So this is looking at term babies that already have had a lot of the major complications excluded. IUGR, for example, prematurity, obviously, and some of the and birth defects, et cetera. And there's a little bit of difference between the different racial ethnic groups here, but it isn't nearly as much as what you see in the other measures. For example, if you look at the third row, non-Hispanic white is 4.19, non-Hispanic black is 4.49. I don't give the confidence intervals here, but they are just a little bit different. Hispanics are a little lower. Again, typically native-born Hispanics do a little worse than foreign-born, but again, these aren't much different. When you look at this is 500. This is a whole year's worth of deliveries to 2014, so it's about 500,000. And you see on the far right column the total population, and then that was what's left after the exclusions is the denominator population. And you can see that most of them exclude about 15%, but it's interesting, non-Hispanic black women have more underlying conditions, and we exclude somewhere around 22%. So there are more exclusions there reflecting the mother outcome. But if you look at low-risk black mothers at term, their babies don't do that much worse on average. And here's another lesson, the on average issue. In averages hide a lot. When we looked at individual hospitals and we looked at what is now becoming a favored way of looking at racial disparity, which is to look at a ratio within the hospital of black to white. When you looked at the ratio for the state as a whole, it was about 1.1, 1.2. It wasn't very much different. So the red line is unity, the ratio 1. So above that means that there are more black infants than white with UNC. Below the line, there are more white infants with UNC than black. And it's about even, which is why the state ends up being about even. But there are individual hospitals here that have much higher rates of unexpected newborn complications among their black babies than their white. And I think this, again, as we start looking at disparity, could well be a marker that we would want to follow up on and say, is there something going on in this particular hospital, even though statewide there isn't much of a difference, but this could be a clue. And this is an approach we're taking with some of the other quality measures too, as we're trying to drill down into disparities. Now, we did restrict this to at least 100 black term infants for the hospitals, so the hospital numbers are smaller. And there are confidence interval issues, sample size issues probably at some play, but probably not enough to account for the ones that are 2.5, 3, 3.5 higher. Those are ones that we think probably have some things worth looking into. So I'm going to show you now a couple of slides from the data center as to how the data is displayed for UNC. In each of these, the orange bars are the hospital, and the purple bars represent statewide benchmarks. So what you can see here, this is one of our hospitals looking at just the simple overall rate and the proportion that's severe and proportion that's moderate. And the overall rate's a little higher, 4.06 versus 3.78, and maybe a little bit higher both in severe and a little bit higher in moderate than the statewide average. So this is sort of, okay, maybe a little higher. What do we do next? And one of the advantages of the data center is that it really allows you to drill down then. So now we're going to look at the buckets, what we call the buckets or the subcategories. In this hospital, the neurological injuries, again, the orange is the hospital, the purple is the statewide averages. A little less severe birth injuries, overall about the same. And you look at respiratory, a little less. Transfer was less than the state average. So the one that sticks out, the biggest orange bar, is infection. And they had a lot of infection and more severe infection. And this really is a marker then for them. If they're going to work on their ONC, they want to focus in on infection and less so on all these other things. So that allows you to do more focused quality improvement projects. And that's a big step forward because you can't address everything at once. This allows you to focus in. So initially, some 3 or 4 or 5 years ago, when we initiated this project, there were naysayers around the country that says, well, okay, we have neonatal morbidities among term babies, but is there anything we can do about it? Or is it just is what it is? So I want to walk you through 4 case studies showing abilities to improve care that have come out of measuring UNC and the ability to reduce rates. So this is case study 1. We had a high rate of moderate respiratory complications. We drilled down to individual cases and found a high rate of CPAP use. And indeed, as was described a moment ago, there was, in this hospital, they were billing for a CPAP for a couple minutes in the DR for resuscitation, and the baby, it was just part of transition. It wasn't really anything to do. They changed that billing practice, and their rate of moderate respiratory complications returned to that of other hospitals. So now we have a hospital that had a lot of moderate birth injuries, high rate of clavicle fractures, 1%, which is a pretty high rate. So we could drill down and saw that it was moderate birth injuries, and then looked at individual cases. And there were 2 physicians who had pretty high rates of elective low vacuum deliveries. And so it was felt that these using operative delivery when you didn't really need to and sort of rushing the baby through the birth canal led to some of these. And again, that was a change that led to an improvement in outcomes. So another hospital had high rate and narrowed it down to severe infection cases. And within the severe infection, it was high rates of septicemia. And here, it was tracked down. This is sort of like being an epidemiologist detective. You track down your data to see what the source is. And there was early term GBS infections that were not, with unknown status, they were not treated, even though the mothers had low-grade temps, 38.3, 38.5 for several hours in labor, and the babies were sicker. So they tightened up their GBS protocols for unknown status. And the last case study is another severe infection one. And this was high rates of babies being treated for 5 days or more in this particular hospital. It really stuck out as a sore thumb. And here was the local protocol of this hospital was to use a lot of C-reactive proteins in treatment, even if the cultures were negative. That was their protocol. They saw they were outliers because they could compare their rates of sepsis to others, and they changed their protocols to less emphasis on C-reactive protein. and then their term neonatal sepsis rates fell into line with other nurseries. So I'm going to talk just for a moment about how it can be used for as a balancing measure. We talked about balance a lot today. Different parts of how it has to be internally balanced as a measure. But then there's this concept of if you're doing an intervention project, like trying to increase the vaginal birth rate, lower the C-section rate, you want to be sure you're not doing any unintended consequences. The unintended consequences here are supposed by some obstetricians that you might have higher rates of complications in the baby. And so as we've done our pilot projects and are moving out our large-scale quality collaborative, we're using UNC as a balancing measure to make certain we can document that there's not any increase in unintended consequences to the baby as we lower the C-section rate. So here are two of our pilot hospitals that we did our QI project with, and we could follow baseline UNC, and on the right-hand y-axis against the NTSV C-section rate on the left-hand y-axis. So over time, at the bottom, every quarter, you can see the C-section rate went down significantly from the mid-30s to right around 25, and the UNC rate stayed the same in the top panel, Hospital 1. Hospital 2 had a little bit, also a big drop, again from 33% to about 26%, and the UNC rate actually improved with time. It was a little higher to start with than the first hospital. This one was averaging 6, and it went down to 4.5. The first hospital was averaging 2% or so and stayed around 2%. So this was very reassuring to the medical staff, and it really let the project continue and reassured people going along. So then we started thinking, well, is there a relationship between UNC and the NTSV C-section rate? It could well be that, you could argue it either way, that a high C-section rate might be related to a low unexpected newborn complications, or vice versa. The more C-sections you do, the more respiratory morbidity you may have. You might have higher rates. And the truth is, it's a wash here. There's not a clean association between UNC and NTSV C-section rate. That low rates of C-sections doesn't give you more UNC necessarily, or less UNC. What's interesting, though, is if you divide it into quartiles, into quadrants, 4 quadrants, and think about what you would like if you were a parent undergoing wanting to have a birth, what would you like to have as the characteristics of your facility? You'd like to have a place that had, good rates of unexpected newborn complications, not the highest rates, but you'd also, can that be paired with hospitals that have low C-section rates? And in fact, this is one way UNC could be used to say, this is a hospital that has pretty fair rates of C-section and good rates of unexpected newborn complications. So that's sort of an idea of what one would like to aspire to be as a birthing facility. You'd like to be in that quadrant. You don't have to be the lowest for either, but you'd like to be in that quadrant if you could. So this is all about getting the right balance. We talked about a lot of these factors, getting the right balance between mother and baby. Like in the last slide, we talked about focusing in on term babies that have no pre-existing conditions. We wanted within that group to be fairly comprehensive of the types of complications we looked at, not just the birth injury ones. And we spent a lot of time on the data collection issues, trying to squeeze the most out of the ICD-9 codes or ICD-10 codes that we can get with built-in protections for overcoding and undercoding. So we're trying to get the right balance. So what our current feelings on UNC is that it represents, reflects the family and patient viewpoint, but it does resonate with physicians. We talk about everybody wants good babies at the end, and people are very appreciative of excluding pre-existing conditions. We have more variation than I expected to begin with, though as the more we work with hospital-level measures, the more variation we see, so I shouldn't have been surprised by that. There are more improvement opportunities than maybe we might have expected as well, and I think this is partly related to the fact that people haven't looked at term babies as an improvement opportunity in the past, and I think there are opportunities there more than what might be expected. And this is a measure that's sensitive to both obstetric practice and neonatal care. So in a sense, this is a really good perinatal outcome measure because both parts play an important role. So I think we have a validated term baby outcome measure, which was our initial goal. We were able to drill down and examine reasons for why your rate may be high and where there are improvement opportunities. We still are unsure of the risk adjustment. We're working on that. But we do note that even within each NICU level, or each nursery level 1, 2, 3, or 4, there's large variation within those levels and a lot of overlap. And certainly this is serving a current purpose as a balancing measure as we look at obstetric interventions such as lowering the C-section rate. So I'm going to end now. We're going to take a few more questions, but as I was going through Google Images looking for images of balance, I came across this one, which was striking. This was an amazing example of balance, and I wish I could do something like this. But I must say, this puts anything that Kim Kardashian puts out there to shame as what you can do as humans. So let me stop and take any questions now that haven't been asked already. Thank you.
Okay. Thank you, Dr. Main. And there are several questions coming into the Q&A box, so let me start. Is there an exclusion for families that decline the recommended practice, such as refusing induction even at 42 weeks and declining a C-section even when macrosomic?
No, we haven't done those types of exclusions. I mean, that's the advantage of being able to drill down and examine your numerators. I suspect those would be very small numbers, and many of those refusals aren't going to end up in an UNC. But they certainly will have a different set of expectations potentially family-wise. So they're not excluded at this point. It would be something worth following and seeing, but we don't think there's big enough numbers to justify that.
Okay, next question. Will something like a heart murmur that could be benign or represent a pathology disqualify a baby from being in the denominator?
If there's a neonatal diagnosis of a congenital heart disease, it would disqualify. If there's not a diagnosis, it would not. Okay.
And there is a follow-up question. So earlier there was a question about using CPAP for 1 minute.
Mm-hmm.
And let me get to the follow-up question. Okay. It says, the CPAP question is worth a little more discussion because it's likely not appropriate to request coders to ignore CPAP or request interpretation. If it is recommended care per AAP guidelines in the delivery room, we need a better way to differentiate.
Well, I don't think AAP calls bag and mask in the delivery room the same as mechanical CPAP. And that is something we're getting some coding guidelines on, but that's very different than being in a NICU where you're getting nasal CPAP. They happen to, yes, it is the administration of continuous positive airway pressure, but CPAP machines are quite different morbidities and represent different morbidities than a bag and mask that's for a minute or two. So stay tuned on that, but that's probably a misapplication of the code.
Yeah, this is Ann Castles. When we had our coding consultant look at this, very difficult to draw a specific line around this and name a specific number of minutes. But in general, his take was if it's under 5 minutes and it's in the delivery room, it should not be coded. So of course there's some gray there still, but just as a general rule of thumb, under 5 minutes in the delivery room should not be coded.
Okay, next question. TTN is a common diagnosis. I understand the length of stay modifier that is necessary for this to be included in the numerator, but I'm not sure how the length of stay is determined to be specific to the baby's condition, since babies will stay with the mother if she stays longer.
Again, we are trying to keep things as balanced as we can with minimal extra data collection. And so these are basically done with the baby discharge diagnosis file, which has length of stay, and it has, and it will have whether it was a vaginal delivery or a C-section. So, you know, TTN is almost always in the case of a C-section. But if you have TTN and you're staying 5 or 6 days, that's going to be a concern. Then if you have TTN and you're going home 3 or 4 days. So it's the best we can do.
Okay, next question. Does transfer to higher level of care refer to transport out only, or does that include transfer from normal newborn to the NICU within the same facility?
This is transfer out to another facility, and there's disposition codes in the discharge diagnosis records that indicate that it's transferred out to another facility. So no, this is obviously babies will move from normal nursery to the NICU, and that's not the same type of coding here.
Okay, just a few more questions. This question is about exclusions from the denominator. This person asked, is all maternal substance use a disqualifier, such as marijuana use during pregnancy, alcohol use, as well as prescription medications such as methadone and Norco?
So this includes, there are a set of codes where it's babies affected by mother's use of drugs, and there are codes for withdrawal symptoms in an infant, and those are the ones that are being excluded. So you could have and neonatal alcohol syndromes excluded. So we're not looking at the mother's record to say that the mother used tobacco or alcohol. We're looking at the baby's record to see if there was coding saying the baby was affected by those. And there are specific codes for that.
Okay, one more question about exclusions. This person asked, what about conditions that are noted during pregnancy but resolve, such as pregnancy that started as twins or previa that is resolved? Are those babies excluded?
No, they're not. There is codes for neonatal codes for baby affected by a placenta previa, and again, previas are fairly common at 16 weeks of gestation on ultrasound. Probably 25–30% of women will have that seen. And most of those move away from the cervix as the uterus enlarges, so they're not a significant issue. If you have a previa at term, which a lot of previas deliver prior to term, but if you have a previa at term and your typical C-section, you can certainly get a code that was an infant affected by a previa, and that would be an exclusion. But again, most of those babies would otherwise be expected to be normal if they were 38 weeks or so.
Okay, you're on a roll. We'll continue with a few more here. Given all this information, Do you have any tips for those of us who have to report or justify our ART PSI 17 birth trauma rates to hospital administrators and quality boards?
I know the recommendation is to ditch the measure, and more places are not using it, and it is not NQF endorsed. Again, it's very easy to do. What you should do is, if you're put in that position, is that you need to look at the numerator cases and to see how many are in that other category, and that's an easy one to work on, fortunately and unfortunately. It makes the measure less valuable when you can just tweak it with coding improvements, because again, this is only 2 per 1,000 births, and so that's 2 cases for many hospitals that have 1,000 births a year. And that's another deficit of this measure. So I would look very carefully at the coding for the outlier, the fallout cases, the numerator cases, and see what's happening over the last couple of years at your institution. Just pull those cases and see. You know, if you have a lot of subgaleal hemorrhages, that's a big deal. So again, it's sort of, in general, for any quality measure, yes, you look at a rate, but the real instructive part is to drill down and understand the numerator cases, you know, what's driving the rate. And then that's the only point you can start doing quality improvement work. So that would be my take-home lesson, is look at those cases and see if you see any trends that you can improve upon. And if it's a lot of other, I think that's a coding issue. If it's the hemorrhage, intracranial hemorrhages or subgaleal hemorrhages, that's a real issue.
Okay, we have one more clinical related question and then 2 data questions. So this question says, hypoglycemic baby that was unable to start a peripheral IV, had a UAC placed for glucose, was a severe complication, but only in the NICU 1 to 2 days. Will the UAC line alone make it into the severe category?
Yeah, that's a pretty invasive line. And so that's why that fell into, you know, the part of that. And when you think about it from the mother's standpoint, here's, you know, she had a baby that should be in the normal nursery, and then got enough complications that not only went into NICU, but then had an arterial line placed. So, you know, that's, quote, not supposed to happen in term babies, and so it meets the unexpected newborn complication definition. You know, for any single case, you may be able to argue back and forth about whether this qualified or not, but we have to deal with you know, all the 1,000 cases in your hospital at once, and so we have to take the averages and deal with it as a whole.
Okay, and this is a question in reference to the maternal data center. Will there be additional comparison screens added to the maternal data center so that you can compare your hospital's rates with similar hospitals?
So that the overall UNC rate will allow you to do that. What's being added to the data center is the ability to look at the submeasures, which I'm particularly interested in, because you'd like to have more of a sense of how you rank versus others for your respiratory, for your sepsis, and for your birth injury in particular, birth injury neurological, and to follow those over time as well as the overall. Now, you know, this isn't a high incident, this isn't a measure with a high incidence to begin with, it's 4%. Give or take, and so you break it into the submeasures, and you deal with 1%, which is getting to small n's, but that is the nature of pediatrics, is it's always about small n's for nursery outcomes. But that would give you a little bit more sense of how you compare. So that's coming within the next 6 months. I don't know the timeline for the production of that, but we've scoped that out to be able to do that.
And this is Ann Castles, the Maternal Data Center Program Manager. Just so folks know exactly where they can compare their UNC rate to like hospitals. So if click into the UNC measure in the left in the left side panel, you can click on peer comparisons or NICU level comparisons, and you'll be able to see your hospital's rate compared to other hospitals that are in your same, that have your same NICU level. Understanding that NICU level is a proxy now, and we don't have maternal level of care indicators, but this is the best proxy we have. If folks do have recommendations in terms of other like hospital categories they'd like to see, there are certain categories that we can actually create on our end pretty easily. So if you'd like a volume-based like hospital category, then let us know, or any other category you can think of, and we can certainly consider it and can sometimes add with very little effort.
So here's an example of, I think, what Ann was talking about with one of our demo hospitals in the data centers. So this is real comparison data with your hospital against your county, against your system, the region, and like-level nurseries, all community nurseries, and the whole state. And what we're going to be adding is the ability to drill down into the sub-measures for comparison purposes as well. You know, and this is, again, showing a little bit of difference. This is the most current data set between regional nurseries being a bit higher. Some of this may well be some of the CPAP coding that's going on in some centers more than others, but this is, but that can be drilled down and determined. So this is all the types of things that you can do, you know, as well as trended over time, of course. And then do it, this is 3 months, and this is a relatively small hospital, so let's do it annually and show that it's, you know, staying right around 4%. It's now down to 3.7%. Other questions?
The last question so far is about data validation, and this comes from a maternal data center user in Oregon. This person says, as I understand it, one of the paths for validating the data is comparing the birth records from vital statistics. In Oregon, we don't have that data in the Oregon Maternal Data Center. Are there other ways to validate that we can bring forward?
So we only use in reality, we only use the birth certificate data in California to clean up a little bit around who's included at the beginning, i.e. the 2,500 gram cutoff point. I'm actually want to do the study to compare with and without birth certificate. I don't think it's going to make a big difference. What you may end up with if you don't have the birth certificate is some additional 36-weekers might slip into it because the gestational age is not quite as accurate if you use ICD-10 codes until we get that down. But if your hospitals are using ICD-10 codes to their fullest, ICD-10 codes now give you the week of gestation. It just has to be used. But there are codes now for every week of gestation that could be used for every birth. So I would work with that in Oregon, and then you really wouldn't need the birth certificate. It's a little cleaner in terms of they double check for IUGR. You know, if you're under 2,500 grams a term, you're by definition IUGR. Or small for dates, excuse me, that's a better term, as opposed to requiring a code for that. You know, so we have those double checks, but that's really the only clear rule. My thinking, the other place we use the birth certificate is APGAR scores, low, you know, 3 minutes or less, or under 3 at 5 or 10 minutes. And again, most of those are going to have other diagnosis codes too that will slip it in. So that's only a double check, to be honest. So we think it's still going to be valid in the absence of those validatory steps. That we think those add a little bit. We wanted to have as clean as possible a data set for evaluation to begin with. And now we can go back and say, well, if we relaxed here, relaxed there, would it really affect it? And I don't think it will. And though I haven't, we should be able to sit down and compare your hospitals in Oregon versus ours in California and see if the distribution is the same. That's not a hard one to do.
Are there any other questions for Dr. Main? If yes, please enter them into the chat box.
Well, thank you for your attention, and the slide presentation will be on our websites, both the data center and the general website, and look forward to continuing discussion as we learn about how people are coding. This is an ongoing process here, and there's certainly the potential to do some tweaks as we learn coding practices. Thank you.
Thank you, everyone, for joining us.
Bye.